A very warm welcome to this talk. My name is Dr. Sayed Kazmi and you're watching the medical channel, which means the world of pediatrics, public health and epidemiology simplified. And in today's video, I'm going to talk about one of the most commonly encountered clinical problems in the field of emergency pediatrics, and that is the issue of interpreting acid-base problems in sick children. Now, we know that a wide variety of diseases can present with acid-base disturbances. We need to detect these acid-base disturbances mostly by the bedside and take initiatives and take measures to correct these problems. Now, how do we detect that? A very simple blood sample, either from a capillary, a vein, or an artery, can help in determining the acid-base status. So in pediatrics, mostly by the bedside, we either use a capillary blood sample or we use a venous blood sample to determine the acid-base status. In very sick children who are admitted in intensive care, then they can have invasive monitoring in the form of taking arterial blood gas samples and determining their acid-base status. Now, in a very ideal situation, arterial blood gives you the best status of the acid-base problems in the body, but nevertheless, capillary blood gas and venous blood gas also give you readings which are very near to the values of arterial blood gas, and they can be safely substituted for an arterial blood gas sample to make interpretations about the acid-base status. Now, you should be clear about a few terms that we use in determining the acid-base status. The term pH less than 7.35 or the pH greater than 7.45, and you should keep in mind that these are the range for the normal pH, that is 7.35 to 7.45. So any blood sample which shows a pH of less than 7.35 simply means that it's got more acid in that blood sample. So that the term used for that is acidemia. If that blood pH is greater than 7.45, it means it has got more alkali in that blood. So the term used for that is alkalemia. So acidemia means pH less than 7.35, alkalemia means pH greater than 7.45. And the processes that have driven that pH less than 7.35 or more than 7.45, they would be known as acidosis and alkalosis respectively. So make sure that you use the proper terms. So if the pH is low, we call it acidemia. If it is high, we call it alkalemia. While the terms acidosis and alkalosis are reserved for the underlying pathophysiological processes that have driven the pH either low or high respectively. Though we use them interchangeably, but you should know that what actually these terms mean. Now, how do we interpret the acid-base status? We need to have a capillary blood sample or a venous blood sample, and we run it in the ABG machine. So the ABG machine then prints a slip which has got all these numbers on it, which helps in determining the acid-base status. So how do we do that? Once we've got that slip which has got all the numbers, we always start by looking at the pH. So I told you earlier that the normal pH is between 7.35 to 7.45. If it is less than 7.35, there is an acidemia and there is an underlying acidotic process going on. If the pH is more than 7.45, there is alkalemia and there is an alkaline process or alkalotic process going on which is causing that. So once if the pH is less than 7.35 or it is more than 7.45, then we need to determine what is the primary disorder, what is causing the acidosis or what is causing the alkalosis. So what do we look at? Step number 2 is to look at PCO2. So if the pH and PCO2 have moved in opposite direction, pH low, PCO2 high, and for that you need to understand what are the normal values for bicarbonate, what are the normal values for PCO2, and obviously I told you about the normal value of pH as well. So if you are using the metric system, then the PCO2 normal values are 35 to 45 millimeter of mercury. If you are using the British system, the SI system, then the values are 4.5 kPa to 6 kPa. Bicarbonates are always determined in milliequivalents per liter. So the range is between 20 to to 27, some books even say 26 milliequivalents per liter. The average value is taken as 24. Okay, so once the pH is low or high, you look at the PCO2. So if the pH and PCO2 have moved in opposite direction, pH down, PCO2 up than normal, or pH up and PCO2 have gone in the downward direction, then the primary problem is respiratory. Whether it's acidosis or alkalosis, the problem is what? Is respiratory. Then you also look at the bicarbonate level. Third step. If they are moving all in the same direction, and especially here I'm focusing on bicarbonate. If pH is low and bicarbonate is low, if they are moving in the same direction, the primary problem is metabolic acidosis. So, or simply, if they move in the same direction, either down or up, the problem is metabolic. If they move down both in the same direction, it is metabolic acidosis. If they both go up, that is metabolic alkalosis. As simple as that. So, first step is to look at the pH. The next step is to look at the primary process, whether it's respiratory or metabolics. In respiratory, PCO2 and pH would move in the opposite direction. And if the pH and the bicarbonate, they move in the same direction, then the problem is metabolic. Here, you should also keep one thing in mind. A normal pH does not exclude acid-base problems. So if the pH is normal, don't think that everything is normal. You still have to look at the PCO2 levels and the bicarbonate level, because sometimes the pH might be normal, but still the bicarbonate level is low. Well, that is an acidosis. If the pH you think is normal and the PCO2 is high, that might be respiratory acidosis. So a normal pH does not exclude acid-base problem. You still have to go through the steps of looking at the PCO2 levels and the bicarbonate levels. So once you have determined whether the primary process is acidemia or alkalemia, and number two, whether the primary process is primary pathologic process is respiratory or metabolic, the third step is to look for compensation. Body always tries to compensate for acid-base problems by, doing something in the opposite direction. So if there's a respiratory problem, the body would try to compensate it by metabolic process. If there's a metabolic problem, whether acidosis or alkalosis, the body would try to compensate it by respiratory adjustment. How it does? You should remember, again, for metabolic acidosis and metabolic alkalosis, there are separate processes. For respiratory and chronic acidosis and acute and chronic respiratory alkalosis, there are different processes. So for metabolic acidosis, where the pH is low and the bicarbonate is also low, for every milliequivalent decrease in bicarbonate, the body would try to compensate it by decreasing the bicarbonate level by 1.3 millimeter of mercury. For alkalosis, because the pH rises, for every 1 milliequivalent rise in bicarbonate, the body would try to compensate by increasing the PCO2 by 0.7 millimeter of mercury. Similarly, for acute or chronic respiratory acidosis, in both these conditions, the pH would be low, the bicarbonate levels, the PCO2 levels would be high. So for every 1 millimeter rise in carbon dioxide levels, the body would try to compensate by increasing the bicarbonate by 0.1 milliequivalent in case of acute condition and 0.4 milliequivalent in case of chronic condition. And in case of respiratory alkalosis, for acute conditions, for every 1 milliequivalent decrease in PCO2, the body would decrease the carbon dioxide level would decrease the bicarbonate by 0.2 milliequivalent per liter. And for chronic, for 1 milliequivalent for 1 millimeter decrease in PCO2, the body would try to decrease the bicarbonate by 0.5 milliequivalent per liter. Now this seems very daunting to start with, because all these equations are a bit difficult to remember. But if you just take a printout of these things and keep you in front of your table, and while you're doing it on a daily basis, when you do it every day, then you would remember these conversion factors on your fingertips. The one thing that sometimes we struggle in the British system is because the machines still use the SI system, so the measurements are given in kPa rather than millimeters of mercury. So you can just use the conversion factors. So remember, 1 kPa is equal to 7.5 millimeters of mercury. So you can do the conversion in that way. Anyhow, so I told you that the first step is to look at the pH level. So pH could be towards the acidotic side, or it could be to the alkalotic side. Then you determine the primary pathologic process. If the pH and the PCO2 is on the opposite directions, either up or down, then the primary problem is respiratory. If the pH and the bicarbonate levels are in the same direction, either up or down, then the primary process is metabolic. Then the third step is to look for compensation. Remember, metabolic processes would be compensated by respiratory adjustment, and respiratory problems would be adjusted by metabolic problem. Yes, the only one thing is, because metabolic problems are adjusted by respiratory compensation, that is very quick, because the body can quickly change the tidal volume and the minute ventilation to compensate for it. So it's quick. But for respiratory problems, the metabolic compensation takes weeks, days to weeks, so that can be a bit delayed. So this is how you do the conversion to see if there is a proper compensation or not. But remember that the body never overcompensates. So it can, by compensation, it can bring the pH back to the normal, but it will never overshoot towards the other side. Like an acidosis would not be compensated by taking the pH toward the alkaline side. No, it would try to bring it towards the normal, but it would never go towards the alkalotic side. This you should also remember. So once you have done these things, you have looked for compensation. Then also look for Anoint gap, because in cases of acidosis, you need to see whether there is a high Anoint gap acidosis or a normal Anoint gap. So Anoint gap is very simple to calculate. You take the sodium value and you subtract the bicarbonate and the chloride values from it, and you get the Anoint gap. So normal Anoint gap is between 8 to 12. Different books use different values. You can stick to whatever textbook you like. Some say 8 to 12, some say 8 to 14. Nowadays it doesn't make much difference, but also keep it in mind that once you have taken the Anoint gap and you think it is normal, you always measure the serum albumin levels, because the Anoint gap has to be corrected for the serum albumin levels, because serum albumin level is very closely associated with the Anoint gap. So there's a formula in which you have to correct your Anoint gap by taking your measured Anoint gap value, and to that you add it's an equation which is measured Anoint gap plus 2.5 and 2.5 times 4 minus the serum albumin level. So that would give you the corrected Anoint gap, because in certain conditions you might think that Anoint gap is normal, but when you correct it for serum albumin levels, you will see that it's actually a high Anoint gap. So for serum albumin levels, especially when they are low, it's very important to correct it for the decrease in serum albumin. And if on the Anoint gap, whether corrected or uncorrected, if you find that the Anoint gap is high, then it's also important to check for the delta ratio. So the delta ratio actually looks, it's actually a sort of difference between the Anoint gap, change in the Anoint gap, divided by change in the bicarbonate level. And the formula is that you take the Anoint gap, you subtract 12 from it, and you divide it by the difference between 24 and the actual bicarbonate level. So Anoint gap minus 12 divided by 24 minus actual bicarbonate would give you the delta ratio. And delta ratio, you can get a value of 1, you can get a value of less than 1, and you can get a value of greater than 2. I will explain that later on in my lecture, what does the delta ratio means, because delta ratio would simply tell you if the process is only 1 or is it more than that. Because normally when we are doing the acid-base status determination, so we come up with something. Okay, we'll say, well, it's a metabolic acidosis, or it's a metabolic alkalosis, or respiratory acidosis or alkalosis, and it's just one thing that we blame, that okay, well, this process is going on. But in reality, sometimes more than one process might be going on. It might be a high Anoint gap metabolic acidosis, and with that there might be a component of normal Anoint gap metabolic acidosis as well, or there might be three things going on, like high Anoint gap metabolic acidosis, normal Anoint gap metabolic acidosis, and a respiratory alkalosis at the same time. Triple disorders, and that can only be determined if you measure the delta ratio, or if you can't measure the delta ratio, then you can check for delta gap as well. And once you have done all these things, and you find a single disorder or double disorder or triple disorder, then you try to correlate that with your clinical finding to see what is causing these issues, and then obviously you try to correct those things. So this table is very important. The more you use it, you will get familiar with this, and you will get familiar with all the conversion processes. I will try to explain it with a few examples. So let's start with the very first example. This is a 16-year-old girl who has got a history of poorly controlled asthma, and she gets repeated episodes of shortness of breath. So she comes in with a respiratory distress, which is mild in nature. Well, you are able to do an arterial puncture on her, and you check an arterial blood gas sample for her acid-base status, and you find that she's got a pH of 7.54, she's got a PCO2 of 29, sodium 138, chloride 103, and bicarbonate of 25 milliequivalent. Now, if you look at the pH is more than 7.45, so this is an alkaline pH, and this alkaline pH means that there is an alkalemia going on. Now, if you look at the PCO2, so PCO2 is less than 35 millimeter of mercury. 35 to 45 or 4.5 to 6 kPa is the normal level. So if you do the conversion in kPa, you just have to multiply that by 0.133, so that would come out with 3.85. So in both cases, whether you take the millimeters of mercury, whether you take the kPa, the PCO2 level is below normal. So pH is up, PCO2 is down. What does that mean? Respiratory problem. So this is a respiratory what? And the pH is high, so this is a respiratory alkalosis. Look at the bicarbonate level. Bicarbonate levels are close to normal. They haven't changed. Now, normally, if the pH is alkaline, the PCO2 is down. So the primary process is respiratory alkalosis. How should the body compensate it? The body should compensate it by making metabolic adjustment. So the metabolic adjustment would be on the opposite side. So the body would try to filter out more bicarbonate. So bicarbonate levels will be brought down to compensate for it, but that has not happened. Okay, so this is an uncompensated respiratory alkalosis. Okay, moving on to the second example here. A 3-month-old baby, he develops increased work of breathing, so he develops respiratory distress. He's got a history of prematurity, and because he was born premature, let's say 30 weeks of gestational age. He's got chronic lung disease, and he is on diuretics, hydrochlorothiazide, spironolactone combination, and his capillary blood gas sample shows a pH of 7.37. He's got a PCO2, elevated PCO2 of 70 millimeter of mercury, sodium is 136, chloride is 88, and bicarb 37. So if you look at pH, now pH here is normal. And I told you that a normal pH does not exclude acid-base problems. So if you just focus on pH, you would say, oh, well, it seems normal without looking at the further values. But if you look down on the value, PCO2 is quite elevated. So if PCO2 is elevated, what does that mean? It means there is a respiratory acidosis component. This is respiratory acidosis. But then look at the bicarbonate. Bicarbonate is also high. Normal bicarbonate should not be more than 27. The average value is 24. Here it is 37. So PCO2 has gone up, and the bicarbonate has also gone up. The only thing is pH in this equation, which is normal. So a primary respiratory acidosis, which has been compensated by increase in bicarbonate level. Now, whether this compensation is appropriate or not, again, we have to go back to that table, look at the conversion table. So for acute processes, 1 millimeter rise in CO2 would lead to an increase in 0.1 milliequivalent in bicarbonate level. For chronic issues, 1 millimeter rise in carbon dioxide would lead to 0.4 increase in bicarbonate level. So here, if you see, if it was just 1 millimeter, if it was an acute process, then for every 10 it would be 1. So for 30 it would be 3 milliequivalent. So it would have been around 30 milliequivalent if that was an acute process. But this is quite high. So this is a chronic compensatory respiratory acidosis. Why? Because the rise in bicarbonate level is more than what happens in acute process. So this is a chronic compensatory respiratory acidosis. And if you look at the Anoint gap, that is normal. Obviously, we don't have the serum albumin levels to see whether we can correct this Anoint gap or not. But anyhow, if we just go with the information that is available to us, this is a chronic compensated respiratory acidosis. Obviously, this child has got chronic lung problem, so he's got an ongoing respiratory issues which might have led to respiratory acidosis, and because it's an old problem, that has been compensated by metabolic processes, and that's why it fits the clinical picture. So this is a chronic compensated respiratory acidosis. Moving on, this is a 2-year-old boy who is found near his family garage with an open bottle of antifreeze. Antifreeze is a liquid which is used in cars to keep the engine cool. Now, he is minimally responsive, so his GCS level is quite low, and obviously he's admitted, blood gas is done, and his blood gas is 6.83, which is showing acidemia. His PCO2 is 40 millimeters of mercury, his sodium is 142, chloride is 106, and bicarb is 6 milliequivalent. So pH is down, and look at the bicarbonate. So pH low, bicarbonate is low. So both down means metabolic acidosis. Both down, metabolic acidosis. If both are up, would be metabolic alkalosis. So here both are down, metabolic acidosis, because pH is low and the primary process is a metabolic one, decrease in bicarbonate. It's just 6 milliequivalent instead of somewhere near around 23 or 24. So how should this be compensated? When bicarbonate is low, the body would try to compensate it by doing respiratory adjustment, and the respiratory adjustment would be the form of blowing off carbon dioxide, hyperventilating, to bring the CO2 levels down. But here look at the CO2 levels. The CO2 levels have not gone down. They're almost normal. So what does that mean? Is it an uncompensated thing, or is something else going on? Because it is metabolic acidosis, what we do? We go and we look at the Anoint gap. So the Anoint gap is sodium minus chloride minus bicarbonate. And if we do that, if you see here, it is 30, which is high Anoint gap metabolic acidosis. If we take the delta R, which is change in the Anoint gap divided by change in the bicarbonate level, so it comes out to be around 1. Now, we know that for an acute metabolic acidosis, the PCO2 should decrease by 1.3 millimeter of mercury for every 1 milliequivalent in bicarbonate. Now, the bicarbonate has gone to 6, which is like, so from 24, it is 18 milliequivalents low. So the PCO2 should go down by 1.3 millimeter for every, so 18 into 1.3, you can do the maths, and the PSO should be around, like, let's say 20 millimeter of mercury by this equation. So PSO2 here should have gone down. If it was properly compensating, it should have gone down to 20. But PCO2 is relatively high. It's relatively high. It's not gone down. It simply means there's another process going on. And that process is secondary respiratory acidosis. So two processes, one is metabolic acidosis and the other is respiratory acidosis. Two things going on. So instead of body compensating it by blowing off carbon dioxide, because there's some other issue going on at the same time, the body is not able to hyperventilate and blow off carbon dioxide to compensate for the metabolic acidosis. So two processes have occurred. A metabolic acidosis, high Anoint gap metabolic acidosis, and a respiratory acidosis. So he's got two issues. And again, we need to find out what is the reason. And if we want to correct this thing, then again, it would help us in the management as well. Because for metabolic acidosis, obviously, we have to, increase the bicarbonate level. We have to give him fluids. For respiratory acidosis, we need to blow off his carbon dioxide. So probably we would need to intubate him and, give him high oxygen and increase his respiratory rate to blow off the carbon dioxide. So this is a case where the pH has gone down, the bicarbonate is low, but the PCO2 is normal. It shouldn't be normal in an acute stage. It should compensate, at least try to compensate it by decreasing, but it hasn't done that. So it simply means there is a second element as well. So this is a double disorder. So there is a metabolic acute high Anoint gap metabolic acidosis with a secondary respiratory acidosis as well. So you can have two problems at the same time. So now moving on to this example. This is a child who has got biliary atresia, and biliary atresia is a condition which can be corrected by a concise procedure, but if the liver is chronically damaged, then it needs a transplant. So this child is awaiting a liver transplant, and he has got the following lab results. So his sodium level is 130 milliequivalent per liter, his chloride is 100 milliequivalent per liter, his bicarb is 16 milliequivalent per liter, he's got a creatinine of 0.4 milligram per deciliter, albumin of 1.8 gram per deciliter, and a cap gas shows a pH of 7.31 and a PCO2 of 32 millimeter of mercury. Now, if you look at his pH, the pH is 7.31, which is less than the normal value of 7.35. So there is an acidemia. The blood is acidotic, and there's an underlying acidotic process. So the pH is down. Look at the bicarbonate level. The bicarbonate level has gone down. So pH and bicarbonate are moving in the same direction, and this same direction is downward. So it means it's an acidotic process, it's a metabolic acidosis. So there is a primary metabolic acidosis. But then look at the carbon dioxide level. The carbon dioxide level has also gone down. The normal levels are 35 to 45. Here it is 32. So the body is trying to compensate this metabolic acidotic state by blowing off carbon dioxide, removing carbon dioxide, bringing the carbon dioxide levels low, just to bring the pH close back to the normal. So you can see that this is a metabolic acidosis with respiratory compensation. Now we do the Anoint gap because it's metabolic acidosis. So Anoint gap is the sodium levels minus chloride and bicarbonate. So 130 minus 100 minus 16 is equal to 14. So you can see that the Anoint gap is normal. So it looks like a normal Anoint gap metabolic acidosis with respiratory compensation. But there's a caveat here. Here we have been given the serum albumin levels, that is 1.8 gram per deciliter, and I told you if the serum albumin level is low, it has to be corrected. The Anoint gap has to be corrected for this low serum albumin by this equation, which is the corrected Anoint gap is equivalent to your measured Anoint gap plus 2.5 times 4 minus serum albumin level. So if we substitute the values, so Anoint gap is 14, okay, 14. I told you some books take 8 to 12, some takes 8 to 14, so close to normal, and we add to it 2.5 times 4 minus serum albumin, which is 1.8, and if we do the maths, it comes out to be 14 plus 5.5, and now it is 19, which is way higher. So this is actually a high Anoint gap metabolic acidosis. So this is high Anoint gap. It doesn't look like high Anoint gap in the very beginning, obviously, because if we just put the values in simple equation, it looks like a normal Anoint gap. But I told you, if the serum albumin levels have been given, or even if you haven't given and you can do the serum albumin levels, you have to correct your Anoint gap for any low serum albumin, and we have done it in this case, and we see that it is a high Anoint gap metabolic acidosis. So there has been some respiratory compensation in this particular case, but this gives but it actually clarifies that if the Anoint gap seems to be normal, you still correct it for any decrease in serum albumin level, and that may give you a surprise. In this particular case, the normal Anoint gap metabolic acidosis became high Anoint gap metabolic acidosis when we corrected it for the low serum albumin levels. Going on to another example, this 16-year-old girl is brought to the emergency department by her parents, and they are concerned because she recently has been very depressed. She is known to the camps, and she has recently threatened to commit suicide. Now, tonight they have found out that she has been vomiting and she doesn't look fine. I mean, she's been acting very strange. So she's brought in. Obviously, you pass an IV line, you do the blood gas. So the blood gas shows a serum sodium level of 144 milli equivalent, and the chloride levels are 100 milli equivalent, bicarbonate is 24, pH is 7.4, and PCO2 is 40 millimeters of mercury. Now look at that. This is a very good example because the pH here is 7.4, which is normal. Okay, fine. I told you a normal pH does not exclude acid-base problem. So you look at the PCO2 levels. Pure sweet level is 40. Again, that is normal. Now you look at the bicarbonate. Bicarbonate is 24 milliequivalent per annum. This is also normal. So when the pH is normal, the PCO2 is normal, the bicarbonate is also normal. Now what do you think? You think, well, the blood gas is absolutely fine. So though the fact that the girl is not acting right and she's vomiting, she might have taken something, but the pH is, but she hasn't got any acidosis or alkalosis. So she seems fine. I mean, there is nothing acute going on at the moment. But this is just a cover up. If we calculate the Anoint gap over here, if you look at the sodium levels, 144, if you look at the chloride level, 100, and if we look at the bicarbonate level, if we subtract, what it comes out to be 20, which is way above 12 or 14, the upper limit that you take. So this is a high Anoint gap metabolic acidosis. pH is fine, PCO2 is fine, bicarbonate is fine. How on earth is this high Anoint gap metabolic acidosis? Now we don't have serum albumin levels over here, so we cannot correct it for any decrease in albumin level. So, well, Anoint gap equation is telling us this is high Anoint gap metabolic acidosis, but the pH, PCO2 and bicarbonate levels are absolutely normal. So this is very important to keep in mind. Don't get fooled by these values if they are normal. Still, if the patient is not right and there is something, you do the equation of high, the Anoint, measuring the Anoint gap, and you might see a nasty surprise. So this is a high Anoint gap metabolic acidosis. When you've got a high Anoint gap metabolic acidosis, the fifth step was you always do the delta ratio. So the delta ratio here is the change in the Anoint gap divided by the change in the bicarbonate levels. So 20 minus 12, 24 by 24. So obviously it comes out to A divided by 0. You can't solve because you will say, oh, well, anything divided by 0 would be infinity or very high. So what we do is we take then the delta gap, and the delta gap is basically the change in the Anoint gap, and you add the bicarbonate levels to it. So the change in Anoint gap is what? Is 8, because 20 minus 12 would be 8, and you add 24, which is your bicarbonate, measured bicarbonate level. What you get? 32. And 32 is high because the normal delta gap is between 18 and 30. So normal level for delta gap is between 18 and 30. So it is 32, which is higher than the upper limit. So it simply means that there is another process going on at the same time. There is a metabolic alkalosis going on at the same time. So this metabolic acidosis and metabolic alkalosis are basically in a sort, they are cancelling out as far as the pH, the bicarbonate and the PCO2 is concerned. But both processes are causing damage to the body. It's not simply causing, like, when you take an acid and you take an alkali and you combine them together and you say, well, fine, they've cancelled each out. Please keep it in mind, even if you take an acid and you take an alkali and you combine them together, that will produce a lot of heat, and that heat can simply burn the tissues. Like, I'm just giving you a simple size example. So the same goes in body. Metabolic acidosis, metabolic alkalosis, they are going on in separate directions. They are damaging the body. But the values, because they are cancelling out each other, so the values come out to be normal, but the processes are going on. So we have to, deal with the metabolic alkalosis, and we have to deal with the metabolic acidosis here as well. So we've got a high Anoint gap metabolic acidosis with a metabolic alkalosis at the same time. So probably the high Anoint gap metabolic acidosis has been caused because the girl has taken some toxic ingestions. Most of the barbiturates or these types of tablets which are used for suicidal purposes, they give you high Anoint, or even methanol, ethanol, things like that. They can give you high Anoint gap metabolic acidosis, but at the same time she is vomiting, so that vomiting has caused metabolic alkalosis. So they have cancelled out each other, and in terms of her acid-base status, you are seeing that the pH is normal, the PCO2 is normal, and the bicarbonate is level. So this can fool you, but you do the Anoint gap, you do the delta ratio or the delta gap, you find out that actually there are two processes going on. There's a high Anoint gap metabolic acidosis, and there's a metabolic alkalosis going on at the same time. So here the importance of delta gap, if the delta gap is greater than 30, it simply means that you have got an alkalotic process going on at the same time. So there's a metabolic alkalosis component as well. If it is less than 18, it simply means that there's a high Anoint gap metabolic acidosis with a normal Anoint gap metabolic. So there are two types of acidotic processes going on at the same time. If it is greater than 30 with a high Anoint gap metabolic acidosis, means there's another process which is a metabolic alkalosis. So this example actually illustrates that the pH or the acid-base status on its face value might look normal, but if you do all these calculations, because your acid-base strip that does not calculate all these things for you, you have to do this calculation on a piece of paper. So apparently it looks normal, and you can say, oh, well, we don't need to do anything because the blood gas at the moment is absolutely fine. There is no acidosis, no alkalosis. But in fact, there are both metabolic, high Anoint gap metabolic acidosis and metabolic alkalosis at the same time. So we need to treat both of them. So obviously one can be treated with fluids. For the other thing, we need to see what are the other clinical features, and we might have to do certain more tests, like probably a toxicology screen, and then if needed, we can give some antidotes. So this example actually illustrates that the values, even if for normal, you still go with the rest of the calculations, because that can give you a surprise that what else is hidden in the face of normal blood gas reading. So this is important to keep it in mind. Now, once we have done all these things, like, we know by, following this in an algorithmic manner, we can determine whether it's an acidotic process, then again it's a respiratory or metabolic, whether there's any compensation, and then whether there is a double disorder or a triple disorder. So once we have identified, like in this case, there is a high Anoint gap metabolic acidosis and a metabolic alkalosis, then we have to find out the reasons for that and then to correct that. How do we do that? Let's move on and discuss that. Now, if most of the times we deal with metabolic acidosis, so how do we further work of metabolic acidosis? Okay, fine, we say it's a metabolic acidosis. Now, what to do? Now, if metabolic acidosis is confirmed by doing your calculations on the the results of the blood gas, next level is to check lactate and ketones. If you see that there's metabolic acidosis. So if there is increase in lactate levels, then you look for hypoperfusion. There might be shock, there might be sepsis. So again, you have to check for any hypoperfusion. If it is systemic hypoperfusion with tachycardia, low BP, fever, you can think of shock. If it is a regional one, like, there's regional hypoperfuration just with, for confined to a limb or something, or it might be a limb ischemia, bowel infarct, or if you don't find any like sort of a systemic or regional reasons hypoperfusion, then you should consider any side effects of the medication, any toxic ingestions, or sometimes maybe even malignancy as well. If the lactates are normal and ketones are high, obviously then you have to check for glucose, because diabetic ketoacidosis might be one of the conditions, or it might be acute ethanol intoxication. If lactate and ketones are normal, in the light of metabolic acidosis, then you look for renal function, because kidneys are the organs which actually regulate your bicarbonate levels. So if the GFR is less than 40 and the Anoint gap is less than 40, you probably have got renal failure. But if the GFR is greater than 40 and the Anoint gap is greater than 20, then you also look for the osmolar gap. And the osmolar gap, if it is a high osmolar gap, then probably somebody has taken toxic alcohol. Or if the osmolar gap is low, then you have to consider certain other conditions, obviously which are beyond the scope of this particular lecture. So in very simply word, just to simplify it, if your interpretation is metabolic acidosis with or without compensation, forget about it. The primary disorder is metabolic acidosis, high Anoint gap or low Anoint gap. You check ketones, you check lactate. If lactate is high, you look for what are the reasons for high lactate, whether it's sepsis, whether it's hyperperfusion, whether it's any toxic ingestion, whether any malignancy. Ketones are high, makes it simple. It might be ethanol toxicity, or it might be diabetic ketoacidosis. If these are normal, look for kidney problems. If kidney problems are there, obviously if the renal failure is there, you treat it for renal failure. If not, then you check at the osmolar gap and you would try to find out the reasons accordingly. If you find metabolic alkalosis, which is a bit not rare, but not that common as we find metabolic acidosis, then the next step is to assess the volume status, whether the patient is dehydrated or not. If the patient is dehydrated, then obviously you have to take the history and see whether he has got any vomiting, diarrhea, uh, things like that, and you try to find out reason for mostly gastroenteritis, or somebody is getting like viral gastritis or contraction alkalosis, or like have been on too much suctioning and G-suctioning, etc., etc. So remember, it's just like rehydrating them accordingly. If the volume status is normal, he's not dehydrated or rather edematous, then you next thing is to do serum electrolytes and check for blood pressure. So if the blood pressure is high, then it's probably because of mineralocorticoid excess, and there is something wrong with the renin angiotensin axis, and you have to measure aldosterone renin levels. Again, that would probably go to the pediatricians to have further workup. But if blood pressure is normal and the sodium is low, then it's probably caused by hypokalemia. Hypokalemia is associated with alkalosis in certain condition. Obviously, that can have many reasons, which would need further workup. But if the blood pressure is normal and the serum electrolyte, especially the potassium, is also normal, then you have to rule out exogenous milk alkali syndrome or exogenous ingestions of alkaline materials. Respiratory alkalosis. If somebody has got respiratory alkalosis, then you have to assess their oxygenation levels. Like, so you look at the SATs level and the arterial oxygenation levels as well. So if it is low, then it's a hypoxemia. So that simply means that there's a pathological process because of which they cannot have complete exchange of gases, especially oxygen. And then you consider all cause of hypoxemia, and this big list of different respiratory problems which can cause hypoxemia. But if the oxygenation levels is normal, then you have to exclude whether the patient is in pain or whether the patient is anxious. In practice, we see many girls, adolescent girls, who come, who are having, they complain of chest pain, they are very much anxious, they are hyperventilating, and that hyperventilation just blows off carbon dioxide and it makes their blood alkalotic. And that alkalosis can sometimes precipitate free calcium levels, and they can have tremors as well. Anyhow, so just see if they are anxious and if there is any pain because there has been any injury, you will treat the pain and anxiety as needed. But if there is no pain and no anxiety, then especially if in adolescence there is a history of using oral contraceptive, there is a history of family history of clotting problems, then you have to evaluate for pulmonary embolism as well, because sometimes pulmonary embolism can present with respiratory alkalosis, the rest of the signs and symptoms would be negative. Again, there is a criteria for that. It's like the Wells criteria, or you want to do CTP. Again, I'm not going to go into the details of that, like what is the criteria and when to do and when to not. It's simple as that. That in that case, you should consider pulmonary embolism as well if there are risk factors. There is no algorithmic approach for respiratory acidosis, because respiratory acidosis simply occurs when the body, the respiratory system is not ventilating properly, and it leads to what you call retention of carbon dioxide. So asthma, obesity, hypoventilation syndrome, and all pneumonia and different types of infections can cause respiratory acidosis. There's a big list of causes. So again, if there is respiratory acidosis and there are chest symptoms and other things, you will treat them accordingly. If there's infection, treat infection. If it's asthma, give them bronchodilators and treat them accordingly. So to summarize all this, remember again, to summarize it just in one paragraph or in a few sentences, you always take a venous or a capillary sample, start with pH less than 7.35, acidemia greater than 7.45, alkalemia, then see the primary disorder. So if the pH and PCO2 are moving in opposite directions, up or down, one way or the other, then it's a respiratory problem. If the pH and bicarbonate are moving in the same direction, either up or down, then it's a metabolic problem. The third thing is to look for compensation. Respiratory problems would be compensated by metabolic adjustment. Metabolic problem would be adjusted by compensation, whether there is a compensation or not. If there is an appropriate compensation, fine. If there is not appropriate compensation, then a secondary disorder might be present. And at the same time, also keep it in mind that a normal pH does not exclude acid-base problems. You can have, a bad acidosis even with a normal pH. The fourth step is to look for Anoint gap. Anoint gap is sodium minus chloride minus bicarbonate. 8 to 12, some say even 14 is normal. If there is a high Anoint gap, then adjust. If you have got the serum albumin levels, adjust it for the decrease in serum albumin levels. The fifth step is to calculate the delta ratio or the delta gap. Delta ratio is simply you take the change in the Anoint gap. Okay, that would be simply Anoint gap minus 12 divided by 24 minus your measured bicarbonate levels, and then you see whether it is 1, less than 1, or greater than 1. If you can't calculate it, then you would go for the delta gap. Delta gap is simply your change in the Anoint gap. That would be your Anoint gap minus 12, and you add to it the measured bicarbonate level. So normal would be 18 to 30. If it is greater than 30, it simply means that there is another process, an alkalotic process going on. If it's less than 18, it simply means a normal Anoint gap, metabolic acidosis on top of high Anoint gap, metabolic acidosis. So this is just to exclude double or triple disorders again. And if there are double, triple disorders, then you have to find out the reasons for that and follow these algorithms and try to find out the cause and treat them accordingly. This is the whole what you call workup and the management plan for acid-base problem. This seems complicated, but it's easy. In fact, the more you do it with practice, you would find out that you are more and more confident in solving these types of problems. Anyhow, if you've got any questions, you can put your questions down in the comment section below and I will answer that. And a final request, if you're watching my videos for the very first time, please do subscribe to my channel because it gives me motivation to make further videos for you people. And if you have liked my videos, give me a thumbs up and share it with your friends. And last but not least, have a good day. Bye-bye.